Broadcasting from the historic Hayburn Building in downtown Louisville, it's time for Single Payer Radio. We're a project of Kentuckians for Single Payer Healthcare, and we are an affiliate of the Kentucky chapter of Physicians for a National Health Plan. And we're a longstanding member, a community partner with Forward Radio WFMP LP 106.5. I'm Mark McKinley, a volunteer with the group. Just want to emphasize that the views and opinions expressed here on Single Payer Radio are those of the speakers and not the station. Real quickly, the Build Back Better plan is in play right now. They're getting ready to vote on that. Today is we're recording Friday, November the 19th. In that plan, there is a healthcare infrastructure and workforce component. $16.16 billion for community health centers in underserved areas, medical schools in underserved areas, National Health Service Corps, Nurses Corps, many areas, Gene, that could really help out our rural communities.
Yes.
And I looked at the press release from the American Farm Bureau. They oppose this bill. So there's that piece of it. And then this morning in the Courier Journal, a Humana representative was able to promote their Medicare Advantage plans, which are part of a Wall Street takeover of Medicare, to the veterans community. So with that, Dr. Flynn, Dr. Shively, it's all yours.
Let the games begin. This is Michael Flynn. Let me begin with the usual disclaimer that any comments that I make represent my personal views and do not represent the views of the University of Louisville or the Department of Surgery.
I'm Eugene Shively. The views that I state do not represent Taylor Regional Hospital nor the Department of Surgery at University of Louisville. Mark, I just got a comment on what you just said about the Advantage plans. They now represent almost half, I think it's 47% of all the Medicare plans. The plans with veterans is very, very interesting. I've seen a bunch of patients who are on this. I have yet to find anyone who quite understands it. Some of the patients are going to VA hospitals, and then they also have private physicians, and nobody seems to know where the money's coming from or exactly where the money's going.
Well, listen, guys, let's not get off the topic here.
Okay.
We need to talk about
I
this
just had to respond
another
to that.
time, you know. All right. So our topic today is a fairly controversial one. It's on LGBTQ and diversity issues, which, as we all know from all of the stuff that's been going on in the news in this country, are major issues. We have a special guest today. Dr. Ganzell, Toni Ganzell, is the Dean of the University of Louisville School of Medicine. Before that, she was an ENT, an otolaryngologic surgeon. She was a director of the Division of Otolaryngology at the University of Louisville. In addition to her medical degree, she has a master's in business administration. So, Toni, we are grateful that you're here to talk to us about these issues. I know the University of Louisville has had some special recognition in the diversity aspect of it, and maybe we can get to that a little bit later on. But as we've done with guests in the past, we'd like to give you an opportunity to make whatever comments you'd like to make for as long as you'd like to make on these issues, and then the conversation will begin. So the floor is yours.
Well, thank you very much, Mike. I appreciate the opportunity to be here. I guess there are two parts to this from the School of Medicine perspective. As a school, we want to be welcoming and inclusive to all students, faculty, staff, regardless of race, ethnicity, sexual orientation, sexual identity, etc. So I think that that's one piece of it. If you look at the business literature, more diverse organizations are more highly performing. You know, diversity of thought, diversity of background. So I think that that's one piece of it. We want to be welcoming to all. The other piece is really related to health equity. We are going to be educating the next generation of physicians, and it's important that our physicians be competent, culturally competent around populations that experience health disparities. And I don't think I really appreciated, before we started our LGBT health competency curriculum, I don't think that I personally appreciated the degree of health disparities that were experienced by our LGBTQ patients. And so I think that it's important for physicians to understand that. We certainly want to promote health equity. You know, your entire radio station about single payer, about access, about care for all is consistent with this. So they're based on evidence and scientific background. There were a series of competencies that our Association of American Medical Colleges recommended that physicians be aware of. And this was a curriculum that we have put into place as part of our cultural competency curriculum for our students. So we have received some recognition for this, and it is important that that this be part of our curriculum. And it's, you know, having cultural competency in your curriculum is something that's absolutely expected by our accrediting body.
Toni, I'm going to let Jean have a shot at you in just a moment, but since you brought that up, the U of L has received it was a Higher Education Excellence in Diversity Award on a number of occasions. Mm-hmm. So could you make a few comments, about that award, the origination of it, where it comes from, and then maybe explain some of the policies, the procedures, or the administrative activities that U of L has done that has resulted in this recognition?
So this HEED award, HEED, Higher Education Excellence in Diversity, is an overarching university award. So I'm not positive of the organization that distributes this, but my understanding is they look at things like programs and practices and infrastructure in place, support services for students, and probably look at satisfaction of students who self-identify as LGBTQ. But in terms of the specific things, I can't tell you that.
Okay, Jane.
I was interested in the fact that, let's say, in OBGYN, there are lots more women in OBGYN than there are men now. Mm-hmm. Does that mean that medical schools and they should strive to get more men into OBGYN? Are we talking about that equality, or are we just talking about getting equal quality of men and women and other minorities in the classes of medical schools?
Well, I think that there are different things going on. Certainly there are far more women that go into OBGYN than men, and that is a choice. You know, students decide what specialty they're going to go into, and patients decide who they're more likely to want to see as a doctor. And in general, at least contemporary women, you know, in the I would say probably 20 to 40s and 50s, do express an interest that they would rather see a female OBGYN. So I guess the question is, are we doing a disservice to society by not having an equal number of men and women in OBGYN? So I don't know. And I think likewise, there are far more men that go into urology than women. And again, that is a choice. And in general, men express more interest in going to a male urologist than a female urologist. So some of this is choice, some of it is patient choice. So I think that if you look at equal numbers as a destination for numbers, it's probably not a legitimate driver for things. If and Mike will talk about our field of surgery. You know, it was absolutely male dominated, decades and decades. There was a push to encourage more women to go into surgery, and I think that has been that has seen some success, and it is. I think that there was a sense, you know, for the American College of Surgeons, for the American Board of Surgery, that surgery did need to diversify a bit as it relates to gender, and they felt that would be a value added thing, not just because, well, the numbers have to be the same, but it is important to have a diverse workforce.
Tony, I absolutely agree with you on two issues. Number one, I think the surgery department at U of L has done a really good job. In recent years, I'm just thinking back over the last 5 or 6 years, there are 4 years, 3 in a row, I think, and one with a skip, in which the administrative resident was a woman. And one of them was a Black woman. So I mean,
Right.
we haven't done a bad job here at all.
No, we haven't. And Dr. McMasters, as the department chair, has been very intentional about wanting to diversify the faculty. He just hired an incredible woman trauma surgeon, academic trauma surgeon, and we're really excited about having her on faculty.
Now, in JAMA, in January, there was an article I was reading that indicated that about 5% of physicians in this country are Black, and the population of this country is 13 or 14% Black. So 2 questions here. One, do you have any similar statistics about Hispanic and Asian populations? That may not be a fair question for you, and if you don't, we can just skip over it. And the other part of that question is what are the issues, the barriers to getting more Black medical students or more Black students into medical school, and how is the University of Louisville addressing that issue?
The statistics on Black and Hispanic Latinx, at least at U of L, if I look at our student population, about 10% of our students are Black. And this year we have a even more diverse class. We've got 12% Black in our entering class this year, 8% Hispanic, Latino. Now, we don't track Asian students because in general, they're not underrepresented in medicine. Again, I go back to what our accrediting body requires medical students or medical schools to do, is to actually identify those underrepresented cohorts that bring added value if we're looking at a diverse workforce, or those that are underrepresented. And you have to identify that at the student level, at the faculty level, and then at the senior staff development. So for our students, those value-added minority or underrepresented categories are Black, Hispanic, Latinx, and rural, because we know that we have, and Jean, you certainly are very, very familiar with the rural underserved areas. And we know that rural students are more likely to go back to rural areas. So we list that as a value added category. In order to, they don't just plop into medical school. You really have to have pipelines and partnership programs, and really pretty early pipelines and partnerships. One of the strongest predictors if a young Black male is going to go on to college is how they score on their 3rd grade reading test, which is just absolutely, as we look at increasing the number of Black medical students, we've done an okay job in increasing the number of Black women medical students. We have really seen those numbers go up in the last decade or so. The Black male students, it's been absolutely flat. We have not made progress at all. And when they really looked at things that would move the needle, it's very early pipeline programs, it's mentorship, it is exposure early on to doctors that look like them, to medical students that they feel like, oh, that could be me, I could do that. Now, if you look at barriers, or is it just the fact, is it a biologic thing? And the answer is no. I mean, if you have 2 Black physicians who have a Black son or daughter, and they've had all the educational and opportunity increases, we're not seeing barriers. But if you have a student from who is economically disadvantaged, and hasn't had the healthcare, and hasn't had the advising, and hasn't had the economic or the educational advantages, it's tough to ensure that individual is going to go to college, much less go on to go to medical school. So I think we've been very intentional in our pipelines and our partnerships, and we are seeing that makes a difference.
Based on what you've just said, a lot of the issues of the pipeline really are beyond your control. I mean,
Absolutely.
all of the Black males in West Louisville who are running around shooting each other with guns, that you can't control that, which you wonder, that was going to be my next question, is how many, where do the ones that get into medical school come from? And I would assume to me that there would be a higher percentage coming from middle class or upper class backgrounds than the ones coming from the west end of Louisville. And
Right. Well, I think that is absolutely true. But if you said the same thing about white students, if they grew up in economically disadvantaged homes, they are less likely to go to medical school than their middle or upper class counterparts as well. But I think it's particularly true of our young Black students. And so again, early on, I think that they need to be identified and nurtured, and make sure that they've got educational advantages and mentoring and support.
Now, that 3rd grade reading thing, where did that come from? I
do not know. And actually, one of
research.
Well, one of my Black dean colleagues told me about that, and I've not searched the paper yet, but he said it's he said it's been absolutely shown that that's a very powerful predictor of whether they're going to continue on and go to high school, where they're going to continue on and go to college. It doesn't predict medical school, but if you're not going to go to college, you're sure not going to go to medical school.
Right. That's a fascinating piece of information. Gene?
Has anyone tracked certain groups, like, for example, Black students? Do they have a tendency to go back to the underserved area and take care of Black patients, or do they just commingle into the population regardless of race or other factors?
Well, in aggregate, they are more likely to care for patients from that underserved background, just like our rural students are more likely to go back to rural areas.
One of the things that we've done, we've been proud of, but we've tried to get students involved in career orientation in high school. We have a Medical Explorer post, which has kind of been down during the COVID, but we've taken junior and senior high school students, and we give them lectures. We let them shadow doctors, veterinarians, dentists, etc. And this has really helped us. In the 80s, we did that, and we have about 7 or 8 students who became doctors, and we have a bunch that became nurses, etc. One of the most important things that we came out of that group is that we had a bunch of students that did not want to go into medicine. And that's probably more important than the ones who did.
Yeah, well, and that's a terrific program. And I think what it demonstrates is the importance of, mentoring and role modeling. And now what we do know about our Black students is probably starting in high school is a bit too late. And we need to even back that up further in terms of the mentoring and the support.
Well, the problem we've had with that is that if we get too young of the students, we have this potential medical legal problems and other problems that
I see.
we're
Right.
concerned
For
about.
shadowing and activities. Yes,
Right.
True.
Now, to get back to the earlier comment about the patient choosing the female, the gynecologist versus going in and the male and urology and female, and just one simple example. My wife has been treated by both male and female gynecologists, all of whom so I'm not going to name any names, but she is clearly in favor of going to a female gynecologist, which is quite reasonable. Now, to carry that over a little bit into the Black community, there was a JAMA issue in this year in which they addressed a lot of those kinds of issues, and there was a number of articles that I read that all came up with the same conclusion, that given the option, the Black community are much more comfortable being treated by Black physicians.
Right.
And taking that one step further, apparently there are some studies that also show that the outcomes are better in terms of decreased maternal mortality and morbidity, and decreased fetal maternal and mortality. I wonder if you have any thoughts or comments about that, because that all that plays into the same scenario of needing to get more Black physicians into practice in various parts of the country.
Well, I think you're right, and I've seen those same studies. What probably is at play is sort of bidirectional, so that if you look at the racial health disparities, for example, that in general, Black women were less likely to get mammograms. Black patients were less likely to be compliant with hypertension medicine. And so there was that piece. And is that a trust issue? Is it an access issue? Is it a trust issue? And if they are more likely to be trusting of a Black physician, they are more likely to be compliant with suggested treatments. And likewise, it may be that the Black physicians are more likely to treat their Black patients in a very equitable fashion, because sometimes those patients aren't offered the same sorts of treatments that white patients are offered.
You know, we had a speaker on, it was a month or so, last month. We talked about VA issues. And one of the aspects of that was a recognition that not only is the VA hospital a place where the veterans could get health care, but it was also a place that they could go to be treated where there was a certain understanding and camaraderie of the things that they went through. So the acronyms that they used and the issues of post-traumatic stress disorder related to deployment, combat, and those sort of things. And I think in a similar way, when you have the understanding, the language, and some of the cultural issues of a Black patient coming to a white physician, and then comparing that with a Black patient going to a Black physician, that there is the similar sort of cultural understanding that they get in that situation. I personally never considered myself, biased or racist or anything, but I don't know that I can understand some of the issues and the cultural situations that are experienced in that community.
Well, and I think I think there is a level of trust that comes from shared lived experiences. And so I think that is part of it.
Yeah. Some of our prejudices are very subtle, though, and sometimes you don't even realize it till you get into an experience that you wake up and say, "Hey, I'm more prejudiced than I realized I was."
I agree. Let's see, probably 8 or 9 years ago, my oldest daughter went to Uganda and adopted a child. And I wasn't opposed to it. I was concerned about all of the issues that this single white woman was going to deal with when she adopted this child from Uganda. And in fact, she did deal with some issues. In order to get the child out of the country, she was accused of child trafficking and had to hire a lawyer and go through a lot of really, really crazy stuff. And this child has just turned out remarkably talented. She has absolutely no accent at all and performs in the New York Youth Chorus. So, but I personally, as you're right, Gene, I didn't know how much of my kind of concern about that was related to the concerns of the factual things or my underlying, bias about things I wasn't familiar with.
Well, actually, in the news just yesterday, there was 3 people were being prosecuted for child putting up children for adoption who were supposed to be orphans, but they really weren't. So this kind of stuff, trafficking, does go on.
Oh yeah, this was a real thing. Toni, let's switch horses a little bit here. I'm gonna try to figure out how to ask you this question. I read an article somewhere I think it may have been in JAMA, New England Journal of Medicine, in which they were kind of addressing the the issues, physician issues dealing with a transgender patient.
Mhm.
And the example was given was how to go through the physical examination and figure out a way to address the need to do a prostate exam on a transgender a female, which I get a little confused about all of the acronyms here, but that's someone with male anatomy who is identifying as a female. Could you kind of give us a few examples or discuss how these things are being approached in the medical school?
Well, I don't claim to have, content expertise in that, in terms of just medical content expertise, but we do have physicians that are far more in tune with LGBT patients than others, and LGBT patients will gravitate towards physicians like that, and so they would know best practices in doing that. But in terms of being a content expertise or being a content expert on that, I really couldn't claim to be.
This is a big issue. I know of an organization just changed some of their bylaws about the transgender issues. They said that in order to be a member, you had to be a biological male or a biological female. The problem is I don't know what biological male is. Is that a XY or? And the whole transgender issue is so complicated that how do you deal with that in medical school? I'm sure there are some people who are prejudiced. Do you have classes on it? How do you deal with it?
Well, yeah, I think the two part is being respectful and inclusive to all of your peers, your faculty, your staff, and then understanding the science behind all of the LGBT issues. And we do have content experts, and this is part of the curriculum in really understanding those nuanced differences between sexual identity versus sexual orientation, and then truly the transgender, which becomes far more complex, either male to female, female to male. And you really need a doc that understands those unique health needs.
Can I change the subject here just a minute to bullying?
Sure.
I know that's a big issue.
Mhm.
And as I think about my career,
Well, Gene, what two of us ought to know about bullying? We both went through general surgical training programs.
yeah, but my responsibility, bullying has been different than a lot of people. I remember in undergrad, I went to undergrad at UOL, and one of my favorite teacher was a really big bullier. And then in medical school, I won't mention any names. He's no longer there. He died, but one of my best teachers was a bullier. I mean, and then of course in residency, the bullying was pretty common, but I was kind of liked it. I mean, it made me really work hard and study hard, and I think the classes that I had with bullies, I did better than the ones I didn't.
Toni, you don't have to answer this question if you don't want.
Well, I think we have. I think we may have different personal opinions on this, and what I would say is that different people learn best in different situations. But at least if you look at the evidence, contemporary adult learners don't appreciate being bullied. Now, there is a difference between setting high standards, and I think that is really important. Having clear expectations and clear performance standards for your learners is really important. But I think you can do that without belittling them or bullying them. And, I mean, it used to be okay for surgeons to throw instruments in the OR. That is not okay now. That is just not okay. And so I think that there are many behavioral sorts of things that, while once, I would say condoned, tacitly condoned by not being confronted. But that's not the case anymore. And the fact that you learned despite, they must have set high expectations for you. And so that was good. And the bullying didn't bother you. So that worked for you. But you may have had classmates that the bullying did bother, and they did not optimally learn from that. So I think that it's not going to be applicable across the board.
Yeah, no, bullying, is an issue. Going through my surgical career, I spent 20 years on active duty in the Navy before I went into a surgical residency program, and was more comfortable confronting those issues because I think it was important to do that. In fact, I wrote an article in Louisville Medicine earlier this year about that. When my son was he went through a series of magnet schools in Louisville, and one of those schools, he was a kind of a scrawny, small kid, and I went down, talked to the teachers in the school, and they all kind of just obviously weren't going to deal with this thing. So I bought a punching bag, hunted up in this is not obviously a way to deal with this thing, but this worked in this case. I put it in the basement and show a punch. And he actually got very good at it and told me maybe a year or so later he was thinking about becoming a cage fighter. And I realized that probably wasn't going to work out well. Well, he's an F-18 pilot for the Navy now. So the end of the day, it worked out all right. But this really wasn't a good way to deal with the bullying issue, except in this particular case, it worked. And I think it's important, certainly as physicians of all categories, to be able to stand up to this and deal with it without punching somebody in the face.
Well, a lot of it depends on what you've gone through with previously. For example, when Frank Miller and I started our residency, and we'd both been in the military, we knew a little bit more about life than people who just come out of medical school.
Yes.
And we didn't take things so seriously as some of the other people who were.
Yes, I absolutely agree with that. Well, Toni, let's back to the LGBTQ issues. Do you have a sense of the percentages of in medical school that folks that I'm a single white guy, and I've just a straight way. This is something that's way off my radar screen. So I can't think of any time during my medical school, my residency training, fellowships, and even practice when I recognized very much of this. And it's much more of an issue today than it was then. So can you put it into a kind of perspective of how much of that's around? I've been retired for 3 years, so I'm off the radar screen anyway.
Well, I think if you look at the general population, and again, this is self-identifying. It's probably much higher that just hasn't self-identified, but it's around 15% that self-identify as LGBT. I don't know if we have I don't think we have I don't think we have any transgender students, but I don't, that probably wouldn't, that wouldn't escalate up to my being aware of it. But I do know that, we have a number of students who self-identify as LGBT, and they've got a kind of a student support group. So, it's something that's not, that's not hidden by any means. We also have a wonderful LGBT center, and we've got a curriculum that folks can go through and get a certificate in LGBT health by attending, so many of these sessions. And we've had just a wonderful array of about 100 people do that each year. And there's some residents and department chairs and staff and students. And so it's a pretty broad array of our School of Medicine family community that says, you know what, we want to learn more about LGBT health. We care about health equity. And the more we learn about this, the better physicians we're going to be.
Do people with LGBTQ tendencies, do they prefer to see other people as patients and than someone who is not LGBT?
My understanding, again, I don't have strong statistics on this, but the studies that I've seen is they want to see an LGBT health competent physician, whether they happen to also be LGBT themselves. Again, that might be more of a sense of connection and trust and shared lived experiences, but I can't speak to that specifically, but they definitely want to see physicians that are competent around LGBT health issues.
Now, how would you find that out? I mean, it's not
word of mouth. I mean,
Yes,
there's all
okay.
kinds of word of mouth,
Yeah, okay.
both good experiences and bad experiences. Avoid this doc, go to this doc. Under no circumstances should you see this doc. If given any opportunity, go see this doc. So there's a pretty strong peer community in terms of that.
Well, that's interesting, because as I was just sitting here thinking, and of all for the first, I don't know, 30 years of my life, I don't think I ever saw a physician for anything.
Or you had to in the Navy.
Well, yeah, but that was just for an annual physical. And but I just don't know that I ever I had some ENT thing done once that my father took me there, but it's kind of interesting that information is around. And I was just thinking, in my own experience, I was no way I would have known anything about anybody. I never went there.
Mm-hmm.
Well, another issue is tribalism. Give you an example. Campbellsville University has about 250 foreign students. I think they have the largest number of foreign students than any other private school in the state. And if you go in the cafeteria at lunch or supper time, all the black football players are sitting at one table, the Chinese students are sitting at another table, et cetera, et cetera. Is tribalism a problem in medical school, or should we try to change that, or is it just natural to want to sit with a European colleague who plays soccer?
Well, that's a tough one to answer. We don't have international students. They had, in terms of just that, they come from medical schools, usually within the United States. If you look at different cultural groups or ethnic groups, they do tend to, I think they probably do tend to naturally kind of congregate together. We need to be mindful as a medical school and intentional to try and, if we're going to learn from one another and if we're going to connect with one another and there's an inclusive environment, I think to create some spaces where everyone feels welcome. But human nature is human nature, and I don't know that we're ever going to completely get rid of, I don't know, guys who went to Center wanting to hang out together, and girls who went to Sacred Heart wanting, I don't know that we're ever going to get rid of that, completely get rid of that natural connection. But we do, when we assign groups, for example, because there's a lot of small group learning that goes on at the School of Medicine, and we are very intentional about assigning groups in ways that is diverse. I mean, is gender diverse, is as diverse as it can be, with racial, as diverse as it can be with backgrounds, in state versus out of state. So we are pretty intentional about that. And I think things like that then become safer environments when, you connect with a small group, and even though they're very different from you, it still feels right if you do it right. And so I think that's something we do want to encourage.
Toni, let me ask you a political question, and if you don't feel comfortable answering it, you don't have to answer it. And before I do that, Mark is letting us know we've got 10 minutes left, so we're getting toward the end here. I remember years ago, I think when Donald Swain was president, they declared the university a non-smoking campus. And the Kentucky legislature went up in arms, and they even threatened to defund the university. I mean, this is so. The legislature today, when you think about some of the things they did to limit the governor's ability to deal with a huge public health pandemic, have you had any sort of pushback? When I think about all the people that are marching into Frankfurt these days in the legislature with their ideological and political beliefs, some of the things we've been talking about are not exactly thing that these people are wild about. Have you had any kind of a pushback or kind of negative response to any of these issues from anybody?
Occasionally, but it's pretty rare. Again, I think if you stay kind of focused on guiding principles of being an inclusive institution, guiding principles around health equity. I think that that you can mitigate some of the discord that comes as a result of that.
Have you had any pushback with mandates for vaccinations?
Well, you've seen in the news, there's pushback by the legislature on mandating, and there are differences in opinions, on that. We have gotten clarity, though, that we are indeed subject to the federal guidelines or the federal mandates now. And so we will, in fact, we just heard from the president today that we're going to be, that we are subject to that. So we will need to mandate vaccines. Now in the clinical, for the School of Medicine, in the clinical arena, since all four of our health systems in the city area mandated vaccines de facto, we had to, all of our clinical faculty, all of our residents, and all of our medical students had to be vaccinated or gain a religious exemption. But very, very few have religious exemptions. And while I don't know who those are, it's way less than 1% for our medical students and our residents. So we have a very, very high percentage of that.
Let me ask you another sort of political question, which again may or may not be an entirely fair one, but I'm going to ask it anyway. As you know, we are sponsored by an organization that's promoting single payer healthcare, Medicare for all. If you look down the road, and it's not looking so good these days, but if you were to look down the road, and if the powers that be in this country, the Congress and the executive, were to come up with either a public option to support healthcare for those folks who are under 65, with an alternative to the existing different entities providing healthcare insurance, or to establish a Medicare for all. How do you see any of that, either one of those or both, playing out in the ability to provide health care for some of the underserved communities? And what effect do you think that might have in the recruitment of Black and Latino physicians into healthcare in this country?
Well, I will be very clear that I believe in access for all. You know, what the optimal model looks like, is that one payer and it's all the government? Is it a governmental option for those that aren't employed and have employer provided health insurance? That I think that remains to be seen. But I do believe that there needs to be a safety net so that all people have access to healthcare, regardless of their ability to pay.
Yeah, you know, our president's having a colonoscopy today.
Well, thank you, Gene. I wasn't aware of that.
And there have been several Republicans who volunteered to do that.
Oh, Toni, we're about to the end here. Again, first of all, I'd like to thank you. You are an outstanding guest, and I hope our listeners have learned a lot about what a remarkable place the University of Louisville Medical School has become under your leadership.
Oh, thank you so much.
Would you like to make any final remarks before Mark gets on to do his final closure?
Just that there are a lot of changes that have taken place in the last decade, and I'm sure we're going to see more changes in the next decade. And I think it's important as physicians, as educators, as researchers, that we keep an open mind, an open heart, and keep the first things first. And that's caring for our patients, that's educating our physicians and scientists in our community for good health.
Okay, thank you again, Toni. Mark, it's all yours.
Dr. Ganzell, thanks very much for a discussion, participating in a discussion on such an important issue. I learned that Dr. Shively likes to be bullied, and I'll try to help him out with that. I didn't know if you do any recruiting specifically to students who embrace a single payer Medicare for all system when you're recruiting your students. I know that the medical school has a pretty strong chapter of folks who support single payer. They've been out to some of our activities, and I really appreciate their advocacy. Again, wanted to remind listeners that the views and opinions expressed here on Single Payer Radio are those of the speakers and not the station. That you can listen to Single Payer Radio each Monday afternoon at 2 p.m. Tuesday mornings at 7 a.m. and Wednesdays at 11 a.m. For more information about getting involved with Kentuckians for Single Payer Healthcare, you can go to kyhealthcare.org, kyhealthcare.org. Dr. Ganzell, is there any website that folks can go to learn more about your all's initiatives on student recruitment for diversity or anything else that you'd like to share with the community?
Louisville.edu, and then, linking to the medical school and linking to admissions would talk about the fact that we have a holistic admissions approach. So we start with talent first, and then we look for all sorts of additional value-added qualities and characteristics as we bring in a wonderful medical school class.
Good deal. Dr. Shively, any closing remarks?
I think the medical student is doing a fantastic job, and we need to be very thankful for what Dr. Ganzell's doing and under her leadership, and the rest of the medical professors at U of L. Where U of L is an R1 university, and some of the research that's being done there is just incredible.
Toni, thanks again, and keep up the good work.
Thank you very much.
Good deal.
We off the air?